Welcome to Compass Opioid Stewardship in Practice. Each week, our Compass coaches will explore a real-world case, define a clinical goal, and walk through practical strategies to improve care. Whether you're tuning in via video, audio, or reading the summary, this session is built for busy clinicians like you. Enjoy the show.
My name is Scott Weiner. I'm an emergency and addiction medicine physician, and I'm a coach in the Compass Opioid Stewardship Program. Today, we're going to talk about a patient who may have opioid use disorder and how you can implement medication for opioid use disorder. We'll cover diagnosis, patient counseling, and how to initiate buprenorphine in the office. Bob is a 50-year-old male with chronic low back pain who's been taking oxycodone ER 20 milligrams 3 times a day for 3 years. He recently has asked for early refills. He reports that he lost his prescription a couple of times, and his urine drug screen test shows fentanyl and benzodiazepines. The state prescription drug monitoring program also indicates prescriptions from multiple providers. This constellation of behaviors, unapproved dose increases, obtaining opioids from multiple prescribers, and concurrent non-medical use may signal increased risk for opioid use disorder. Bob insists he is taking opioids for pain, but admits to buying additional pills to avoid getting sick. We want to determine if Bob meets the DSM-5 criteria for opioid use disorder, counsel him on treatment options, and start buprenorphine in primary care to improve his options, his outcomes, and reduce overdose risk. How to reach the goal. We're going to talk about 6 steps. Step 1 is to recognize the opioid use disorder. The DSM-5 criteria lists 11 factors, the presence of which 2 or more in the previous 12 months indicates opioid use disorder concerning behaviors such as using more opioids than intended, unsuccessful attempts to cut down, spending significant time obtaining opioids, craving, failure to fulfill obligations, continued use despite problems, and tolerance and withdrawal. These all count towards the criteria. But note that tolerance and withdrawal do not, in themselves, count unless they're accompanied by the other criteria. Bob buys pills from an illicit source. He's exhibiting loss of control. He's using more than prescribed. And he continues use despite harms. He therefore meets criteria for at least a moderate opioid use disorder. Step 2, we're going to discuss treatment and obtain consent. Explain to the patient that OUD is a chronic brain disease. Medication for addiction treatment, also called MAT, reduces mortality and improves retention and treatment. Emphasize that he will receive counseling and support, not judgment. Because he has benzodiazepines in his urine, caution that combined sedatives increase overdose risk. Arrange for a benzodiazepine taper as well. Provide naloxone spray to Bob and his family, as patients on more than 50 MME per day or using benzos plus opioids should carry naloxone. Step 3, initial assessment before induction. Confirm the OUD diagnosis. Obtain collateral information from his medical records or pharmacy. Perform a physical exam and consider a baseline drug screen, not for punitive reasons, but rather to see which substances need to be addressed. Assess for other substance use. High-volume alcohol or benzodiazepine use may require inpatient induction. Evaluate his support systems, his housing stability and insurance. Refer to counseling and recovery programs. Step 4, choose an induction strategy. There are 2 main approaches. There's the standard induction, where you wait for moderate withdrawal, and low dose, or often called microdosing, cross taper. For most patients using short-acting prescription opioids, the standard induction is recommended. And in this, what you do is wait until the patient exhibits moderate withdrawal with a clinical opioid withdrawal scale, or COWS score, greater than 10 to 12, typically 12 hours after the last opioid use. Start with 8 to 16 milligrams of sublingual buprenorphine, reassess after 1 to 2 hours, and then give additional doses up to 24 to 32 milligrams on day 1. On day 2, take the total dose from day 1. You can also consider adjuncts like clonidine, ondansetron, or hydroxyzine for withdrawal symptoms. Step 5, and this is the low-dose microdosing cross taper, which is optional. If Bob cannot tolerate withdrawal or is on long-acting opioids or fentanyl, consider microdosing. There's lots of ways to do this, but they usually involve starting with a low dose, like 0.5 milligrams once or twice per day, and then slowly ramping up over the course of 5 to 14 days. Step 6, follow-up and harm reduction. Schedule frequent visits or telehealth if you have availability during his first month. Do not stop buprenorphine if the urine screens show continued opioid or stimulant use. Instead, assess adherence, consider dose increase, and provide additional support. The clinical pearls we want you to remember are, first, diagnose OUD using the DSM-5 criteria, including loss of control, cravings, and continued use despite harm. Second, offer buprenorphine in primary care. Any clinician with a Schedule III DEA registration can prescribe it for OUD. Third, prescribe naloxone to the patient and his household. Those taking more than 50 MME per day or combining opioids and benzodiazepines should have it on hand. Initiating buprenorphine in primary care is a powerful way to treat opioid use disorder and reduce harm. The COMPASS program provides clinical protocols and patient education tools to help guide transitions like this. For personalized technical assistance, reach out to your clinical coach to schedule a coaching session.
This show has been brought to you through the generous support of the Centers of Medicare and Medicaid Services. Thanks for joining this week's COMPASS Opioid Stewardship in Practice. Thank you for being part of the COMPASS Opioid Stewardship Program, and thank you for all you do caring for your patients. See you next time.